Hi, my name is Leanne Camacho. I will be presenting for the early childhood stage of development, which is also known to be the ages 2 to 6 in children, and my presentation will be a discussion of ADHD and the potential modification of its diagnosis and treatment in children aged 2 to 6. So to begin, what exactly is ADHD? ADHD, as defined by a scientific paper made by researchers at the National Center for Scientific Research in Athens, Greece, a paper published in 2019, ADHD is defined as a neurological disorder characterized by a lack of attention and impulsivity, which is a result of a dysfunction in areas of the brain that control certain abilities, including, but not limited to, short-term memory, flexible thinking, and self-regulation. So as mentioned in a scientific journal by Theme Connect in 2020, ADHD is classified in the DSM-5, which is also known as the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, and is generally comprised of 11 symptoms of inattention and 9 symptoms of hyperactivity and impulsivity, of which the DSM-5 distinguishes ADHD to have different presentations. So the 3 presentations that are noted for those diagnosed with ADHD include predominantly inattentive, predominantly hyperactive or impulsive, or a combination of both. The same journal suggests that ADHD should not be diagnosed if the behavioral symptoms can be better explained by other mental disorders, such as psychotic disorders, mood and anxiety disorders, personality disorders, and any other type of disorder that can better explain these symptoms rather than ADHD. And a lot of these disorders generally do not occur in the early childhood stage, especially like substance intoxication, psychotic disorders. These are disorders that typically occur later in life once a person begins to develop more into adulthood. But ADHD is generally considered to be a disorder that is first noted in the early childhood stages, as I will now discuss. So how does the disorder affect the early childhood stage? So during the ages of 2 to 6, children are beginning to understand their mind's beliefs, emotions, intentions, as well as quickly developing a vocabulary, as well as their learning styles. So when it comes to their learning styles, this is when children start to it kind of becomes to be notable whether children have any differences or complications with learning in the way that their peers might, which is where the conversation of ADHD can start to come into play. So ADHD is commonly seen in children, according to the paper published by the National Center of Scientific Research in Athens, and is known to be the most diagnosed behavioral health disorder in the pediatric population. So for adequate diagnosis, symptoms should be present in by the age of 12 for at least 6 months and have to reduce or impair social, academic, or occupational functioning. So according to the National Institutes of Health, the median age of onset for children with current ADHD was 6 years old, based on the most current research available, but more severe cases of ADHD in children are actually generally diagnosed earlier at the ages of 4, and milder cases of ADHD are generally diagnosed later in childhood in the ages 7 to 8 or above. So now I will begin to delve into the diagnosis of ADHD in young children. So as per an article by the American Academy of Pediatrics, factors that are typically considered an ADHD diagnosis include a comprehensive history, taking of prenatal, perinatal, and family history, school performance, environmental factors, and detailed physical examinations that evaluate vital signs and mental health assessments. So the objective assessments typically used are limited in clarifying the diagnosis, including neuropsychological tests and imaging. Although ADHD has a high heritable estimate, which is about 76%, no specific genetic pattern has been shown to be necessary or sufficient for the disorder to be diagnosed, which suggests that ADHD is generally not correlated with any sort of genetic pattern. It means that ADHD is generally comes about with other like abnormal structure in the brain or other behavioral or mental impacts that happen early in childhood. So what are some of the complications with diagnosis of ADHD in young children? So despite an overwhelming body of research on ADHD over the last 10 to 20 years, valid neurobiological markers or other objective criteria that may lead to unequivocal diagnostic classification are still lacking, as per the scientific journal published by the Find Connect in 2022. Many studies have shown that behavioral ratings of ADHD, symptoms, or questionnaires on executive function are not or weakly correlated with NP test performance. ADHD symptom rating scales also do not predict results on objective attention or executive function tests and vice versa. For example, although mild intellectual disability and low IQ are more typically associated with the disorder, ADHD can be encountered across the entire IQ spectrum, including highly gifted children. This goes directly in contrast with the general perception that ADHD is something that should be tested when a child begins to show low academic abilities when they're first starting out in school in the early ages, or simply not catching up with their peers. So there is a misconception there that children with ADHD generally are just not as academically developed or intellectually developed as their peers, when in reality, ADHD can appear across all IQ spectrums and is more related to the behavior component of the child's neuropsychological mindset. So therefore, it is suggested that intelligence tests should be part of the diagnostic procedures, but are not mandatory according to ADHD guidelines, as some children, intellectual difficulties and not ADHD may be the underlying cause for ADHD-like behaviors, while in other children with ADHD, academic underachievement, despite a high IQ, may be present. Additionally, it has been argued that symptoms defining ADHD may be understood as dimensional markers of several disorders belonging to the ADHD spectrum, and in consequence, the diagnosis of these behavioral symptoms should be considered to be a starting point instead of a general endpoint. So the suggestion is that this suggests that ADHD is definitely a broad and complex disorder that cannot definitively be diagnosed based on just some biological and behavioral markers, but rather should begin with those markers and then lead to more in-depth diagnosis after other factors are considered. So additional factors that can impact future ADHD diagnosis, as per Anna Maria Driga and Thanasios Drigas of the National Center of Scientific Research in Athens, Greece, they say that external socioeconomic factors that have been proven to influence ADHD symptoms include excessive electronic usage at an early age, incompatible parenting styles that can aggravate the child's condition, children raised by single parents, and on the side of biological gender, those that are born biological male, as it has been proven that those that are born biological male have a 3 times higher chance of being diagnosed with ADHD at a younger age than those who are born biologically female. Some additional research that they mentioned in their paper include that children being cared for by a single parent were more than 50% more likely to be on ADHD medications, and additionally, women with secondary education had a 130% higher chance of their children being treated for this disorder. In addition to that, families on welfare also had a 135% chance of having their kids on medication. So all of this research and all of these results show that socioeconomic factors actually can play a big role in the presence of ADHD, the diagnosis of ADHD in a young child, and also how that diagnosis is treated and managed as a result. So while these factors are likely not the sole additional factors influencing ADHD prevalence in young children, taking note of these trends brings to question what the typical ADHD diagnosis methods should be, and how to include additional abnormal trends in a child's behavior or I apologize. So taking note of these trends brings to question whether typical ADHD diagnosis methods should be modified to include additional abnormal trends in a child's behavior, or socioeconomic factors which could therefore lead to increased rates of young children receiving proper ADHD identification, diagnosis, and subsequently treatment. So what are these ADHD treatment options that we currently have? and what are the alternative options that can be explored for better management of the disorder. So all guidelines of ADHD treatments recommend a multimodal treatment approach in which psychoeducation forms a cornerstone of the treatment and should be offered to all of those receiving an ADHD diagnosis, as well as to the families and caregivers of these children that are currently being diagnosed with ADHD. And this is per the scientific journal that was published by Think Connect. As for ADHD medications, they should generally only be prescribed by medical professionals with trained expertise in ADHD to ensure that the child is in adequate health and does not have other underlying factors such as cardiovascular disorders that could affect the effectiveness of the medication as well as cause any negative side effects. And some commonly prescribed medications include methylphenidate, lisdexamfetamine, atomoxetine, and guanfacine. To be specific, methylphenidate is typically diagnosed as short or long-acting preparation as the first line of medication for ADHD across the entire lifespan, starting from when a child is typically first diagnosed, and then the other medications are typically considered the second lines of defense. Specifically, a switch to lisdexamfetamine is only recommended in children that have first undergone at least a 6-week period of methylphenidate usage at an adequate dose and have not derived sufficient benefit in terms of reduced ADHD symptoms and associated impairment, or if patients experience adverse side effects of the initial methylphenidate medication. So what are some, in discussion of alternative options for ADHD treatment, there are notable drawbacks to ADHD medications and typical treatments that have also caused common treatment plans to come into question. So ADHD is usually accompanied by further emotional or behavioral disorders, as per the scientific paper published by the National Center for Scientific Research, meaning that in 75 to 80% of all cases, ADHD kind of leads to further negative emotional and mental impacts. ADHD has also been found to aggravate emotional disorders alongside raising the risk of cardiac and liver malfunction. Some alternative treatment options, as a result, include targeting brain training or working memory that can improve intelligence and attention as well, especially if begun earlier on when children are first diagnosed. This is linked to reduced hyperactivity, inattentiveness, and impulsivity, and improved concentration and attention spans in patients suffering from ADHD. Other options referenced in the paper include using neurofeedback to monitor brain training in patients where electrodes can target certain areas of the brain, acting according to the responses of the patient's brain. Brain training using neurofeedback was proven to be of even higher quality than normal computerized brain training, according to the paper, and showed similar or higher progress in patients on medication as a result. So my conclusion is that while there are factors that appear in early childhood that are generally accepted as typical traits or signs of ADHD, there is evidently room for connections to be made between ADHD and more external factors that can improve future forms of diagnosis. So investigations on additional signs or traits that have potential positive trends with ADHD diagnosis can eventually lead to decreased rates of misdiagnosis in early childhood and of individuals that go undiagnosed into adulthood, as they did not show the typical signs of ADHD in their early stages, which I have discussed is a big misconception based on these research papers and further findings that have determined that there are many factors aside from just the neurological standpoint, the neurological structure, as well as intellectual performance in school, as well as all those other factors. Additionally, once a child is diagnosed, a wider variety of treatment plans can allow for a child to receive proper treatment with less risk of adverse events. And these are my references for the presentation. Thank you to anyone who decided to view my presentation, and I hope you learned something about ADHD and the prevalence that it has in early childhood, as well as how it can be modified in the future to improve rates of diagnosis, proper diagnosis, and more adequate treatments. Thank you to anybody who is watching, and I hope you have a great rest of your day or night.